Later of this session. The most important special feature of Venkatraman sir is when it comes to delivering the lecture, the way he delivers the lecture with stylish English, I think that nobody could come close to him. I used to be always envious about him. See how he put that very appropriate word. Of late, I am reading a lot of Times of India newspaper and everything to pick up very rare English words. But whenever I learned the rare words, but he simply used all these words, I don't know. So, such a fantastic and very brilliant sir. In fact, I used to admire him always, for the substance and the content, the way he delivers. In fact, I'm so glad to be part of this program. In fact, I want to thank each one of you for dedicating this program. In fact, you might have learned or you might have heard about all intimately related to diabetic topics, everything. But this one, it's very quite new to everybody. So when I asked GVK sir, please give me some topics, then suddenly I think that he, selectively he chose very dry topic and simply handed over to me. So I couldn't deny it because I want to grab this opportunity very strongly. And before that, I want to have one request, sir, that could I take that extra 30 minutes time? You told you have spared 30 minutes of time. Okay. I think that sir spared another 5 minutes, I think so. Yes, sir. Yes, sir. Okay, fine. So let me talk about the topic properly. So my session consists of why labyrinthine dysfunction is so important, and what is labyrinthine, and what are the functions of labyrinthine, and what are the diseases that are arising from labyrinthine dysfunction, and how to differentiate each of them, and ultimately what are the differential diagnoses. So many times. So I want to please put your ears on this sentence. This giddiness simply mimics the giddiness of posterior circulation stroke. Please remember that the posterior circulation stroke is very common in diabetics. They simply present with giddiness, and most of the time I have witnessed the giddiness of posterior circulation stroke is simply suppressed with all kind of labyrinthine sedatives, namely Vertin, Stugera and everything, and we used to lose lot of precious time when it comes to posterior circulation stroke, because posterior circulation stroke, something like MI, it also it demands much precious time, because something like MI, if somebody presents with posterior circulation stroke within 4.5 hours, that particular posterior circulatory block can be thrombolized. If you fail to diagnose very appropriately within that 4.5 hours of time, then if you think the giddiness of posterior circulation stroke, something like any other giddiness, then you will lose the precious time. Then I think that you are going to incur permanent morbidity on the patient neurological system. So for that sake, I think that you have to put these ears on this sentence. And since spectrum of treatment is entirely different, it is very prudent to know the clinical features of each. So let me talk about the labyrinthine proper. Please understand that labyrinthine is, as sir told it, labyrinthine is situated in the inner ear, precisely telling it is in the petrous part of the temporal bone. Okay, so it consists of 3 parts. So the most anterior part is cochlea, and the second one is vestibule. The vestibule itself consists of 2 parts. One is utricle and sacule, and the posterior most part is semicircular canal. Thus I want to repeat: cochlea and the vestibule and semicircular canal. This is a bony structure. The bony structure contains one fluid that is called perilymph. Okay, this bony structure in turn contains one membranous structure. This membranous structure is otherwise called cochlear duct, then utricle and sacule and semicircular canal. In this, all these membranous structures contain one fluid that is called endolymph. So what is the clinical significance of this structure? First most important is this utricle. The utricle contains one important calcium carbonate crystals. That calcium carbonate crystals that are present in the utricle receive the information of our head position. This calcium carbonate crystals, when it is detached from the utricle and when it enters into the semicircular canal, then there is one problem arises that is called benign paroxysmal positional vertigo. So the detached calcium carbonate crystals entering into semicircular canal leading to the benign proximal positional vertigo. Then I told that all the this membranous structure contains one fluid that's called endolymph. Okay, endolymph. When the accumulation of endolymph is more or the endolymph volume is more, then that disease called Meniere's disease. So just I want to highlight how it is relevant to our day-to-day practice. What size? I am not. I don't know, sir. So probably the ENT surgeon may know. Yes, sir, because they are operating, of course, definitely. Okay. So what are the functions of these structures? Of course, cochlea is concerned with auditory functions, and the vestibular and the semicircular canal associated with maintaining the balance of our head and body. So there is slight difference between these functions. For example, the vestibular maintains our head position with relative to the gravity. That means the vestibular helps in balancing the head movements, upward head movements and downward head movements and lateral headward movements. Whereas semicircular canal maintains our head movements in such a way that it is associated with maintaining your head rotation. That's all. So the cochlea associated with auditory function, the rest of the structures are associated with balance. So generally postural stability, so for example I am standing in this stage, this postural stability depends upon not only the vestibular system, so namely vision, very very important. So unless you have intact vision, so you will have some kind of postural instability. One, intact vision, and second one, peripheral nerves, especially large fiber nerves. Large fiber that carries position and vibration maintains your body in the space and the gravity. And third one, as I told you, vestibular system, and of course cerebellum. So any of the system, if it is compromised, then that will lead to imbalance. So then we will come to proper vestibular system. So normally vestibular system receives the input, okay, then it sends the impulse to the central nervous system. Then central nervous system in turn sends impulse to the eyes and our spinal muscles to maintain the posture. So how it maintains the posture? There are two reflex are there. One is vestibulo-ocular reflex, another one is vestibulospinal reflex. What do you mean by vestibulo-ocular reflex? See, for example, in every day we engage in day-to-day activities, okay. So at the time, what happened, when you make head movement, okay, normally our eyes tend to move the same side. But when the eyes tend to move the same side, along with head movement, then what happens, you won't fix up the images. So what happens, when you immediately move the head, eyes also move, then probably your eyes won't capture the images, then there will be some confusion. So God has designed this vestibulo-ocular reflex in such a way that when you make head movement on one side, your ocular movement will be on the opposite side to fix up the images, to make sure that the images will be registered in the retina, then in turn will be sent to the cerebrum. So this is called vestibulo-ocular reflex. Then what do you mean by vestibulospinal reflex? So when you bend forward, when you bend lateralwards, what happens? The vestibular system senses that, it sends impulse to your neck muscle, that is called colic reflex and vestibulospinal reflex. So because of this, it maintains a posture. So how diabetes affects the vestibular system? Like any other cells in our body, the vestibular system also affected by diabetes. You are all aware that this AG, advanced glycation end product, and the polyol pathway, protein kinase. So the very interesting phenomenon of polyol pathway is, so when excess glucose is converted into sorbitol, so what happened? The excess glucose will be utilized, glucose normally enters into TCA cycle with the help of hexokinase enzyme. So when more glucose enters into the cell, so what happened, the hexokinase that is normally present in the TCA cycle will be exhausted. So glucose will be forcibly converted into other pathway that is called glucose orbital fructose pathway. In this pathway, what is the most disadvantage is, when this abnormal pathway occurs, our body diverts all reduced NAD, oxidized NAD and NADPH. These enzymes are diverted. What happened? The four important molecules, there will be reduction in the diabetic. One is reduced glutathione and nitric oxide, which is responsible for vasodilatation, and myoinositol. It is very helpful for myelin sheath formation, and taurine. All these products normally will be formed, but these resource materials are diverted For sorbitol pathway, when these materials are decreased, what happens? The overall the cells are affected, the vestibular system also, it's not spared. So what are the clinical tests for that? So one is the Romberg sign is there. What do you mean by Romberg sign? So ask the patient to stand with the feet closed each, okay? With the feet closed. So while eyes are kept open, what happens? The intact eye will mask everything. For example, I may have vestibular dysfunction, I may have a large fiber pathway, large fiber neuropathy, but when my eyes are kept open, the intact visual pathway will compensate all the abnormalities, okay? But while eyes are kept open, even at that time I have giddiness, then think of cerebellar lesion, okay? So now, when the eyes are kept open, the patient stands okay, then ask the patient to shut his eyes. When his eyes are kept closed, then when I have some kind of swaying of the body, then think of two abnormalities. One is his large fiber affected, maybe diabetes or any other pathway, then you may have vestibular abnormalities. Then in turn, then you have to do further tests to differentiate all these things. So what are the diseases that are arising from labyrinthine dysfunction? One is benign paroxysmal positional vertigo, and second one Meniere's disease, and third one vestibular neuronitis. As I told you earlier, benign paroxysmal positional vertigo, even though the word denotes benign, probably it's benign in nature, but only one thing is it is very sudden in onset. So okay, the spinning movements will be very much life threatening. The patient will feel that it is life threatening. As I told you earlier, it is the simple logic would be the detached calcium carbonate crystals entering into the semicircular canal. So what is the treatment? The detached calcium carbonate crystals that have entered in the semicircular canal should be brought back to where? In the utricle. So that is the treatment, but the treatment would be very astonishingly, it is a maneuver, not your beta histine 13 or not your stemetil. It is a maneuver that will cure the patient. One is the Halpic maneuver. I think it is freely available on online, but you can, because this maneuver can be done by any general practitioner. It will cure the positional vertigo, not your medication. And so by Halpic maneuver, when patient develops nystagmus, then you are dealing with positional vertigo. With Epley's maneuver, you can cure the disease.
Video is not available.
What, sir? Yes, sir, video is not available because the time is very short, so I didn't prepare. So what is Meniere's disease? As I told you earlier, this is the hydrops of endolip, otherwise called, there is a more endolip fluid accumulation. The etiology remains unknown to everybody. Here, since the fluid accumulation is the main problem, the one of the treatment is diuretics. Please remember that the vertigo or spinning movement of benign positional vertigo is always only the vertigo. Meniere's disease, apart from spinning movement, additional symptoms will be there. Meniere's disease, hard of hearing or tinnitus, or you will have earfulness. So suppose if you diagnose a patient with vertigo, positional vertigo, if the patient has additional symptoms, please revise the diagnosis. Benign paroxysmal positional vertigo, they will have only vertigo. There will be no other extra ear symptoms. So vestibular neuronitis, it is an inflammation of the vestibular nerves. So again, you will have the spinning movement. The difference between the rest of the two different diagnoses, the vertigo of vestibular neuronitis will last for hours, sometimes weeks. But benign paroxysmal positional vertigo, the vertigo lasts for only 1 minute. When they move the head, they will have giddiness. Then Meniere's disease, they will have same type of giddiness with additional ear symptom. But vestibular neuronitis, they will have giddiness that will last, vertigo will last for hours together. Okay. This is one important test, is head impulse test by which you can diagnose, this vestibular neuronitis. It is also freely available. Then the most important differential diagnosis, and in fact, that's the most important carry home message for us, is nothing but posterior circulation stroke. So the giddiness of posterior circulation stroke mimics exactly your ENT problem, but please explore additional symptoms of another 5 Ds, okay? Apart from dizziness, please think of dysarthria, dysphagia, and so on. double vision, double weakness, because posterior circulation stroke is nothing but involvement of the brainstem, all third, fourth, fifth, sixth, all the cranial nerve will be nucleated. So any patient who presents with giddiness, please ask additional 5D symptoms. If additional 5D symptoms, rush the patient to MRI to rule out posterior circulation stroke. If possible, refer the patient to stroke unit very immediately to thrombolyze. That is a very, very take home message of this one. And another important is middle cerebral artery stroke. They will present with weakness, so it will be very easy for physician and the patient attenders to appreciate the MCA tertiary stroke. And posterior circulation stroke, the predominant symptom will be dizziness, that will mask the other symptom. Then we will be tempted to give all kind of labyrinthine sedative that should be avoided at any cost by means of clinical examination. So differential diagnosis, as I told you earlier, is a large fiber neuropathy monofilament test by which you can think it. And another diagnosis is basilar migraine. Now it has been changed to MBA, migraine with brainstem aura. So generally this basilar migraine usually occurs in female. There will be no comorbid illness, occurs in 20 to 30s age group. They will have exact brainstem symptom, all the dizziness, dysarthria, something like posterior circulation stroke symptom, but the symptoms will be very short-lived. Within 1 hour they will recover. But despite even though suppose even they don't recover, then I think that you have to think of posterior circulation stroke. This migraine with brainstem aura, they will present with extreme occipital headache. That may differentiate between the rest of the diagnosis. So how will you approach when somebody comes with giddiness? I humbly request to rule out always central cause, I mean posterior circulation stroke. Explore all the Ds, dizziness, diplopia, dysarthria. If any additional Ds are present, you should be very careful. Don't get tempted to give all kind of labyrinthine sedative. If central origin, if yes, go for MRI imaging, refer to neurologist. If it is no, then think of ENT causes. If it is only episodic, short-lived, just 1 minute's vertigo, think of benign paroxysmal positional vertigo. Rule out with Halpich's maneuver, treat with Epley's maneuver. That's important. And if it is the vertigo is a little bit constant, more prolonged, think of vestibular neuronitis. I think that will be revealed by head impulse test. If any kind of confusion, refer to ENT. I think that when somebody comes with giddiness, other than medical problem, I think that better you can act like a mediator to refer either to ENT or refer to neurologist, and I think that you can get reputation from all the 3 angles, from ENT, neuro and patient attenders. I think that that may be the end of my home message. But sir? Yes. Only once, sir. Only once. Yes. Yesterday also I demonstrated one patient. If some volunteer is there, then I will demonstrate. It's a very, very simple, sir. Actually, I will try to demonstrate. So just prepare the patient sitting on the couch. Okay. So ask the patient to sit up. Okay. Then turn the head 45 degrees to the right while sitting on the position. Okay. Once he turns to the right, immediately lie back quickly. The head should hang beyond this couch. So at that time you have to observe. If there is any nystagmus during the procedure, the diagnosis is over. This is benign paroxysmal positional vertigo. Don't medication anything. This is called Halpich's maneuver. This is a diagnostic maneuver. Sit up the position, right side, lie back quickly, observe for 30 seconds any emergence of nystagmus. If nystagmus is there, diagnosis is over. Then treatment starts immediately. You have to proceed with Epley's maneuver. Once the right side hurt, should be turned to the left 90 degrees. Then patient should be sit up. He should look at his knees. Then the giddiness will gradually come down. It's almost a curative treatment. Suppose if patient has a recurrent problem, then you have to think of any calcium crystals in anterior semicircular canal. The commonest blockage is at posterior semicircular canal, where it would be helpful. But once patient gets cured with maneuver, then he comes with 3 months, another this kind of thing, then probably it may be anterior semicircular canal. I think the demonstration of all this maneuver beyond this scope of this program, I think so. That's a chronic vertigo is maintained by us. Because when you suppress with labyrinthine sedative, you are changing the acute vertigo, benign positional vertigo into chronic vertigo. Yeah. Yes, sir. Thank you.